So the few of you who ate lunch quick and came back on time, thank you very much. I appreciate it. Hopefully we don't have too much of a post-lunch glucose depression here and keep you awake. Now, let's see. Can my slides come up, guys? Okay. We're going to talk about liver injuries today. So you say, we treat all these livers non-operatively, so what's the big deal and what's there to talk about? So what I want to just show is that even though we do manage a lot of liver injuries non-operatively, it doesn't mean it always ends up that way. One of the problems with the liver is the liver bleeds. It bleeds, and I like this slide just to show all the different blood vessels. There's a whole bunch of vessels within the liver, but besides the aorta and the cava being right there, you have the portal system, and then you have the hepatic vein. So it's a very, very vascular structure that when it does get injured can really, really, really bleed. So this is a busy slide, but I want you to just look at all the yellow arrows. And this is an algorithm for non-operative management of liver injuries, but every yellow arrow takes you to operative management. So even though we try to, there's still a number of indications to operate on patients with liver injury. So what are some of the risk factors that predict patients having complications from liver injuries managed non-operatively? This was a study we did a number of years ago of high-grade liver injuries, and on the x-axis is the number of units of blood the patients received, and the y-axis the probability of complications. I don't think I have a pointer here. You could see that even for grade 5 injuries, if they have 0 units of blood, they have about a 35% incidence of complications, and then complications for all grades increases exponentially with any blood products that are transfused. So what are the complications? So obviously there's bleeding. There's a patient with a blush. Abdominal compartment syndrome, which thankfully we don't see nearly as often as we used to with our former resuscitation techniques. There's biliary complications, both a biloma as well as bioperitonitis, which we'll talk about. And there's infection-related complications, so liver abscesses, hepatic necrosis, which gets secondarily infected. So the timing varies. Not surprisingly, bleeding is early. Almost all patients with a liver injury who bleed quickly. A little bit different than spleens, which have a higher risk of bleeding up through, days and sometimes weeks. And then the infectious and the biliary complications, these are a little bit harder to figure out because they can happen quick. They can happen while the patients are still in the hospital, but sometimes it's weeks and weeks and sometimes even months that they'll present with particularly some of the biliary complications. So what are some of the complications we see with non-operative management? We're just going to kind of go through these. So I mentioned the liver abscess. So, a patient comes in with a liver injury, they've got a continued SIRS response, maybe a little belly pain, now they're febrile, not looking so good, so you get a follow-up CAT scan and you see a liver abscess. Most of the time we will try to manage it non-operatively, interventional radiology, place a drain. Sometimes it works, sometimes it doesn't. The liver, when it gets necrotic and infected, it's just kind of this thick black crap that's kind of hard to get out of a little drain. So some of these patients need to be operatively debrided. And then there's the biliary complications. A simple biloma, which, some people could argue probably will go away on its own, but not always. And sometimes you need to place a drain in these patients and they could drain. And if it stops and it's low volume, that's fine. But some of these patients will have quite high output. And in those patients, you might want to think about doing an ERCP and sphincterotomy. They can also present with bioperitonitis. So this is the patient comes in. Typically, they're hemodynamically stable over the next couple of days. Their belly's big, it's distended, they're a little tachycardic, they have a low-grade fever, maybe a little white count, just don't look good, and they just don't feel good. You're not really usually worried about a missed abdominal injury, but they're just kind of not chugging along as you think, and there's a lot of fluid on the CAT scan. These patients do really well just with laparoscopic drainage, just draining out. It tends to look like this black tarry stuff that comes out. It's blood, but it's also bile. Just draining those, putting a couple drains by in the perihepatic space. And at least in my experience, a lot of these patients do have fairly high output and need to go on to ERCP. this just, and what I try to do, there's not a lot of very recent literature on liver injuries, so everything I'm showing you is pretty much the latest that I could find in whatever topic. So this just talks about preventing the sequelae of bioperitonitis by laparoscopic evaluation. Again, it's high-grade liver injuries. It's usually after a couple of days, and they're just kind of not recovering like you think they would. And the patients do dramatically better. It's pretty interesting. They can wake up from anesthesia and they look better, they feel better, and say thank you for operating on me, which most patients don't really tell us. So ERCP, it works. You know, bowel leaks aren't that common, and they're particularly not very common in patients that are managed non-operatively. This is a study of about 1,500 patients. A very small percentage of them had to go on to get ERCP. Again, it's high-grade injuries. It could be blunt or penetrating, and almost all of these patients were managed operatively. Again, so except for the bioperitonitis patients, most blunt liver injury patients managed non-operatively are not going to need this. So this is one of the more recent papers looking at the success of non-operative management of high-grade liver injuries. Again, we all know grades 1, 2, and virtually every grade 3 does just fine. It's really the grade 4s and 5 that run into problems and the ones we need to think about. Now, this was a retrospective study, fairly large, almost 400 patients, 11 trauma centers in New England, all high-grade, all grade 4 and 5. Almost 40% of these patients needed operative management initially. And the majority of them were for hemodynamic instability, and most of them, as I mentioned, were in the immediate presentation, but there were a number of patients that went on to have a delayed surgical procedure. And they looked at what they call failure, and they said failure is any patient who needs a delayed operation. So about 8.8% of these patients failed, again, not very high. Majority of these were liver-related rather, and either bleeding or bioperitonitis. Again, these were patients during their initial inpatient management. And they looked at the risk factors for patients that would fail, and not surprisingly, a lower admission blood pressure predicted, as well as concomitant other abdominal injuries. This is important because I'm going to talk about another study in a minute. This study showed no increase in mortality, suggesting that even if you make the wrong decision or something happens or they have some complications, they do just fine, you know, and within reason, it's okay to manage these patients non-operatively. Now, this study is published a little bit before, and they called it the swinging pendulum, and they looked at the NTDB patients, much larger, 3,600 patients with high-grade injuries, and they looked at recent trends in non-operative management. So I thought this was kind of interesting. You know, we all say no one who's hemodynamically unstable should go to the CT scanner, but that's not really what we're doing. Not surprisingly, more patients that were hypotensive failed non-operative management, but I just found the statistics, the percentage of patients who are taking to the scanner unstable, a bit alarming. But this, I think, is the take-home message. They looked, if you failed non-operative management, did it have an impact on mortality? And you can see in the black line that patients who failed initial decision for non-operative management had a significantly higher mortality. In this study, suggesting that if we make a mistake on admission, that there is significant sequelae, death, in these patients, and that we need to really think carefully about our initial decisions. So this study is also retrospective, also high grade, and it was done in Houston when I was there. And this is kind of interesting, and I think it sort of explains the last study. So we looked at changes in resuscitation, kind of pre-damage control resuscitation versus post-damage control resuscitation. Now, the study I just showed you that showed a higher mortality was in the pre. This is still when we were using the crystalloids, still not using high ratio resuscitation. So they looked at, there was no difference, so patients were evenly distributed, high grades in all of them. And then they looked at survival. So same grades, you know, same ISS, you know, pretty much matched patient populations. Again, just a different in resuscitation over time. And if you looked at patients who required blood and looked at survival, those patients in the pre-damage control had a significantly lower survival than patients in the post-damage control, suggesting again that maybe it's our resuscitation strategies for these patients rather than maybe our decision to manage operatively or non-operatively that's making the difference. If you looked at patients that received blood, again, consistent with other literature, in the new strategies that we use with higher plasma and better ratios, patients actually get less blood. And despite there being more survivors, you could think, well, if more of these severely injured patients are living, it wouldn't be, surprising if these patients had a higher incidence of complications, but they didn't. There was no significant difference in the complications, even though more injured patients were surviving post-damage control. So maybe the study that I showed you about the swinging pendulum, maybe those patients had a worse outcome because of the resuscitation strategies we were using. I don't think that negates the concern, though, that we want to make the right decision up front. All right, so what if non-operative management doesn't work and we have to operate on the bleeding liver? Again, it's not very common anymore, but it's not zero. This to me was a pretty scary study. It was published by Drs. Lucas and Ledgerwood a number of years ago. And quote, a fully trained surgical resident would perform some type of hemostatic technique to control liver bleeding only 1.2 times in their residency. So residents just aren't getting to see bleeding livers like we used to, and that was not that livers are, we're operating on them, the injuries themselves are worse, but we used to operate on everybody with blood in their belly as opposed to just those who are dying of exsanguinating hemorrhage. So now when we take these patients to the operating room, it's not for a little bit of bleeding, it's not for an easy technique, it's really because they're exsanguinating, and these surgeries can be extremely technically difficult. I'm just going to briefly mention Reboa. It can get you to the operating room, and this is just a film from a patient that I operated on with a severe liver injury. Probably of all the abdominal injuries that you would put in a Reboa in for, probably the liver is the least responsive just because it's got the significant venous inflow and outflow that I mentioned in the beginning. I really do believe, though, it saved this patient's life. It did not control all of the bleeding by any means, but instead of having blood up to my, wrist or up to my elbows when I released it, I could at least sort of figure out where the liver was with it inflated. So it is just something to think about in these patients that have exsanguinating hemorrhage. It at least gets you to the operating room until you can get some control. So operative management, so bleeding, minor is pretty easy. And we just see this now if we're operating for another reason and maybe they have a little liver injury. It would not be the reason we take someone to the operating room for exsanguination. But if you do, you get in there's a belly full of blood, you look at the liver, there's a liver injury. The first thing we recommend is that you pack. And what you're really supposed to do is not put the laparotomy pads, as you're supposed to pack with your hands and sort of compress the liver, pack around it, resuscitate the patient, and while the packs are in place, you could quickly look around the rest of the abdomen, quickly control whatever the injuries are, and then decide, am I going to keep these packs in, or is this going to be a damage control procedure? And for most of these patients, if there's really significant bleeding, once you put those packs in and they're in, you should make that decision quickly. So then the next question is, okay, so now I've got this bad bleeding liver, I've got all these packs in there, I'm going to take them to the ICU, I'm going to resuscitate them, but if they were bleeding this bad, what are the chances of them having a significant arterial injury? Do I want to have an angiogram or at least a CT scan to show me that there's not arterial bleeding before I take these packs out? And that's sort of the thought here. When you do take them back, you want to look around the liver. If something's dead, debride the liver then, control any additional bleeding. The omentum is a great patch. It helps with hemostasis, helps prevent bioleaks. And then if, sort of the dictum now is if you see a bioleak at the time of take back, we recommend placing in a drain, but not like we used to where everybody got a drain placed. So what about this angioembolization? If you have a bleeding liver and you do an angioembolization, it works. I mean, it does stop the bleeding. It can lower mortality, and particularly in some of the older studies. But particularly when it's done for operative patients, particularly those with damage control, resuscitation, and packing, there are a number of complications that occur, particularly hepatic necrosis. So the specific subset of patients that would benefit most from a hepatic angiogram is not well defined. And I think that's still a true statement. I think we're still not sure who really needs to have it. going to talk a little bit about CAT scan because now we don't really do angiograms like we used to. What we used to do, and still is a fine practice and still can be done, if you have a really bad injury and you get them controlled with PACS, we would just go straight to angiography. But now, it's pretty hard for a patient to get through trauma without having a CAT scan. So if we're going to do a CAT scan, can that tell us the need for angiography? And this was a study just presented at last year's the year before Western Trauma Association meeting. It was a multi-center retrospective study, and we looked at that very answer. Patients who came in unstable, went right to the OR, had their livers packed, and then went to CAT scan. Again, not because you're looking at the liver, but all these patients, you're looking at spine injuries, head, C-spine, whatever. They had a CAT scan. The presence or absence of a blush, does that correlate at all if they had with an angiogram? So only 27 of these patients went from the OR to the CT scanner, which I actually found pretty amazing, that low percentage, but there was a high percentage also of penetrating trauma in this population. But if you had a positive blush on CT scan, it was 83% sensitive for a positive angiogram. And likewise, the absence of a blush on CT scan had a specificity of about the same for either a later negative angiogram or simply someone that didn't get one but didn't bleed. So it seems to be a pretty good predictive tool. So if you take someone from the operating room and you do a CT scan immediately afterwards and there isn't a blush, in most cases you're going to be safe to take that patient back the next day or later that night, whatever, and take out the PACS without encountering significant arterial injury, or bleeding rather. I thought this was a study, I just kind of ran across it the other day. It was called Blush at First Sight. And what they did, they looked for both liver and spleen. So they said, if you have a blush on CAT scan and you go take the patient to an arteriogram, they do the agram, and there's no blush seen on agram, and so the radiologist said, okay, there's nothing to embolize, I'm not going to do anything, what happens? Interestingly, it's not a huge study by any means, but I think it just gives us something to think about. Patients who had a blush on scan and not on agram and did not get embolized had a 32% incidence of rebleeding. Hadn't seen that data before, but I thought it was pretty interesting and makes you think maybe if you see it on CAT scan that maybe we should be embolizing these patients. So major hepatic necrosis, I mentioned this before, seems to be seen in operative patients, those with damage control, laparotomies, high-grade injuries, patients that had angioembolization. And this one study was actually done in shock trauma a number of years ago. 42% of these patients developed hepatic necrosis. I wonder, and I have no data to support this, if we don't look at this in current days with modern resuscitation, I'm wondering if maybe the incidence of this is decreasing simply because the patients don't get the amount of bowel edema and the amount of liver edema that we saw with our old resuscitation techniques. I don't know the answer to that. The other thing I think that may be helpful also is we used to keep PACS in for a couple of days, 24, 48, hours, and now because we could correct the coagulopathy so quickly, I think the trend is to take these patients back much sooner, and therefore the PACS are left in not as long. Just some thoughts, no data, but something to think about. So again, the risk factors for hepatic necrosis, pretty much you always have to get operated on, you had to get an agram, and you had to get damage control surgery. So if you have patients, with that combination, at least need to think about it. And if you find it, the question is now what do you do? So this was another study done out of shock trauma, and again, I found just the more recent literature on this. It's a small study, only 30 patients, of which had hepatic necrosis, and they said, well, what's the best way to treat it? You can go to IR, you can put a drain in, the drain gets clogged, you can put another drain in, the drain gets clogged, you put another drain, you go on and on and on and on, or you can just say, okay, this is enough, we're just going to go to surgical resection. So when they looked at this, their outcomes were similar, so there was no difference in mortality, but the serial debridement group, had the IR drain, then went to the OR, a little bit scooped out, on and on, had higher complication rate and increased number of procedures. So they concluded that early lobectomy was better. There was also the group out of Pittsburgh at about the same time also published their series on looking at surgical resections as opposed to debridements for the management of liver injuries. So I don't know how many of you know Dr. Red Duke, but he was a dear friend of Alicia's and mine, and recently passed away. But he had a slide, an old-fashioned slide, and he always used to show me, and he used to talk to me about how in the old days, the treatment for liver injuries was you just took out the part of the liver that was injured, and he had these slides of blood everywhere, and he's like, I know, we used to do that, Rosie, and it was a bad idea. But as we talk about the pendulum swinging, I think the pendulum is swinging a little bit more, and maybe it is okay to sometimes do a resection, whether it's anatomic or non-anatomic, in some of these severely injured livers. Again, with resuscitation, I think it's a little bit safer, and particularly those that have large areas of hepatic necrosis, as opposed to keeping them in the hospital for weeks and months during these serial little scoop outs and drains and everything. Okay, so now you get there and you put the packs in, but it doesn't work so well. They're still bleeding. So the next maneuver you're supposed to do is a Pringle Maneuver, and that's placing I just learned about this little trick here, this is fun, placing a little occlusion around the portal triad. So the idea of that is that you occlude the arterial inflow. So if your bleeding stops, oh, okay, there's an injury within the liver, an artery that's bleeding, and it gives you control, and then you can go in the liver and try to find the bleeding vessel. I like history. This is an old paper. This is when it was initially described in 1908 by Dr. Pringle. The hepatic and portal vessels were grasped between fingers and thumb as soon as the abdomen was opened. The method acted admirably. Perfect control of the bleeding areas of the liver were obtained. I'm still waiting for perfect control, but in 1908, Dr. Pringle found it. Now, it's even worse. Okay, so you find it. So then you can find the bleeding vessel, and then, as I talked about, I think putting in a mental patch in is a great trick. It was described in the 70s. We don't so much put the sutures in like we used to, again, because of the risk of hepatic necrosis, but placing the omentum in the injury and around the liver, I think, is a great trick. Okay, so now you do your Pringle, so uncontrolled bleeding. Pack doesn't work. Pringle doesn't work. This is a really bad sign. If none of those work and you have uncontrolled bleeding, then you have to consider, in fact you have, some type of juxtahepatic venous injury, either retrohepatic cava or hepatic vein injury, and this is not a good injury to have. It is not a good feeling when that happens to you. So my advice is to call for help. This is not something you want to do alone. You want to have the most senior person with the most experience in there with you. You want to notify the blood bank. If you haven't activated your massive transfusion protocol, you need to do so. You need to let anesthesia know that this is going to be bad. Get ready. So what are your options? So you could directly repair the injury, or you can place some kind of shunt and repair. And there's all kind of papers written about, shunts and so forth. Both of them have very high mortalities, and they are both done best at a delayed operation. So if you get in there, and I still remember this one kid I operated on actually for a pancreatic injury, and I was showing the resident how you can miss a diaphragm injury, and I mobilized the left lobe of the liver up and heard this audible bleeding. I mean, literally audible bleeding, and I knew there was hepatic vein injury, but I was able to control it. No way this was going to stop on its own, but I knew that's what it was, and we were then able to do veno-veno bypass. At least we were set up for that. We ended up directly repairing him because he was hemodynamically stable. To do direct repair, you have to occlude the suprahepatic cava, usually the pericardium, and then below, just above the renals, the IVC, and then occlude the porta. And so you're removing all the blood, and if the patient is hemodynamically unstable, they'll die. I mean, you just cannot do this in a hemodynamically unstable patient. I was fortunate in this patient that he wasn't unstable. We were able to do this and directly repair in a couple of seconds, but the confluence of the right and middle hepatic vein were completely separated. I don't know how he survived with a few packs for a while, but he did. But veno-veno bypass, if truly you have one of these injuries, is probably the best option. It's not something you need to do frequently, but when you need it, it's really great to have. And again, the more stable the patient and the more corrected all the coags are and so forth, the better the outcomes will be. We don't have it yet, but I can't imagine in the future there won't be some type of stent graft that we could do to place for these juxtahepatic injuries. So in summary, the majority of patients can be managed non-operatively. However, non-operatively managed patients can and do develop complications, and a number of times these complications require operations. The complications, as I mentioned, are bleeding, abdominal compartment syndrome, biliary complications, and infectious complications. Damage control techniques, when they're needed, should be employed early. If you look at the original paper that talked about damage control surgery presented by Dr. Rotundo a number of years ago with the AAST, I still remember him talking about it. It was actually done for liver injuries, because if you let these patients bleed, they get coagulopathic, they get cold, and they die. So if you're going to do damage control, it's not once you've taken the packs out and futzed around and tried to suture out the liver and the patient's got a blood pressure of 60 and an INR 3. You make that decision early and stick with it. And lastly, call for help with severe bleeding not controlled with packs, because it's a bad injury and something we don't see very often. And I thank you.